Let's talk about how education is done in the outpatient setting. In a typical encounter, a resident will talk with a patient and do a history and physical. That resident will then move on to talk with an attending and chief that patient. The attending will then give guidance and feedback. Sometimes after an encounter like this, a resident will feel like he has more questions than answers. But hopefully that attending will provide some helpful education through reading. Let's take a look at my desktop. Check out all these files. They're chock full of readings that I was supposed to do in the outpatient setting. With the best of intentions, I've filed them away, but they've just built up over time. Your desktop might look like this too, and you wouldn't be alone. But there's got to be a better way, right? What if we flip this whole sequence on its head? What if we started with the common pitfalls and challenges that our trainees face, and then appropriately prepared them for the encounter ahead? Then when they went in to see their patient, they'd be much more competent and confident in their encounter. And as a result, the chiefing process would be much more effective, efficient, and accurate. This is what I'm calling patient-centered didactics. Sure, appropriately prepared them, but what does this really look like? Here's one option in the form of an email. Let's go through it piece by piece, tying each component to educational theory. So the nice thing is you can address it to any number of individuals, so you can have as large or small a group of learners as you need. The subject line allows you to do efficient searches and organize the education by topic. Next, you can create a personalized component by addressing each learner individually. Then we move on to relevance. Giving a resident a reason to learn about a specific topic and tying that topic to a patient they are going to see in the coming days can motivate self-directed learning. Next, providing learners with objectives that are specific, measurable, and attainable ensures the resident that their time is being spent wisely. Providing trainees with a conceptual framework of the subject is by far the most difficult part of this process, but it provides the scaffolding on which they will insert later information learned and build upon their base of knowledge. One of the best things about email is all the media you can include, links to podcasts, videos, photos, diagrams, etc. Now all this newfound knowledge would be totally irrelevant if there wasn't a way to use it. Explicit directions for how to put this knowledge to use is imperative. But the learning shouldn't stop there. Discussion questions keep the learners engaged and thinking beyond just the length of the email. Lastly, keep it personal. Sign off in a specific ways that ensures the learner that you're thinking about them specifically and you care about their learning. Just like PowerPoint lectures, you can have a small library of topics that come up frequently in your clinical setting that you can recycle through residents. Yeah, but who needs another educational strategy? Let's think of it from the vantage point of the patient, the attending, and the resident. The patient feels undue anxiety as a result of the resident's incompetence and inability to provide reassurance to the patient. The attending feels frustration having to correct missteps that the resident has made. And the resident experiences shame-based learning, a standard of our status quo. Let's contrast this with our patient-centered educational process. Here, patients are calm and collected, having just experienced a competent and confident resident. Attendings are delighted, having time and energy to focus on the art of medicine. Lastly, residents feel proud that they've been able to put into practice something that they've learned. But this is all theoretical. Don't take my word for it. Here are some examples from the feedback we've received from residents after 2 years of practicing this model of education. This resident is commenting on decision making, which clearly impacts patient care and satisfaction. What's most impactful about these comments is how this educational model directly influences patient care. In educational history, we've moved from teacher-centered education with the sage on the stage to student-centered education. I believe now we're at a point where we need to shift our focus again to the reason that we're learning what we're learning: patience. By appropriately preparing our residents for clinical encounters, we can make patients the center of education.